Hi, right, okay, today we're going to look at the anatomy of Erb's palsy, something that might be better named as an upper brachial plexus injury. So what we'll need to look at, we'll need to look at the brachial plexus, but not the whole thing in detail in its entirety. We'll need to look at the two roots that are most commonly affected, and this is an upper trunk, a superior trunk injury. So we'll look at that trunk, and we'll look at the nerves that run into the upper limb that tend to be affected, the muscles that they affect, and explain why that gives us kind of the classic or typical or general presentation that we often see with an Erb's palsy or an upper brachial plexus injury. All right, that's the plan. I find that, well, I struggle to remember complicated things. But if I can work something out, I can more reliably reproduce that working out every time I need to. So this is what we're going to do. We're going to try and work out why we get this sort of presentation of the limb when the upper brachial plexus has been injured. And this is a very busy working university today. I can hear the medical students having some clinical skills training. We're having a new, is it psychiatry or pharmacology department built above us, so there's drilling and banging and rumbling. Marcy's about to do some human tissue teaching, so I think we'll hear a whole bunch of students trundle past, and as you know if you watch these videos, we've also got a creche around here, so look forward to the extra sound effects. Could you imagine the luxury of working in a studio that's like soundproofed and stuff? Okay, what are we talking about? This topic is of particular interest to obstetricians. We're talking about, the brachial plexus is so what's a plexus? A plexus is like bundling of your cables. You've got lots of little wires, you bundle those wires together and you create a thicker wire. That might be a nerve. You bundle those thicker wires together because they're going to the same place, and you need to take some off and send them to another place and bundle them to some other wires. That's a plexus. So this is the brachial plexus here. This is the neck. This is the shoulder region. Here's the upper limb. The brachial plexus is that bundling of wires, that bundling of neurons as they come out of the cervical spinal cord and pulling the ones that we need together and separating them out as we pass inferior to the clavicle and into the axilla to form the nerves that are going to run to the upper limb and innervate the muscles of the upper limb and carry sensory information back from the upper limb. So that's the brachial plexus. And the brachial plexus then is a little more at risk of damage than other plexuses, plexi, whatever you want, plexuses around the body, because of the freedom of movement, the range of movement that the shoulder region has in the shoulder girdle. The injury tends to be caused essentially by the shoulder being pushed away from the head. Right? The brachial plexus, as we said, is running from the neck to the upper limb. If you push the head away from the shoulder far enough and with enough force, you can stretch part of the brachial plexus. The upper part of the brachial plexus, which is why this is called an upper brachial plexus injury. You can imagine that, this upper part here being stretched. So we talk about damage to nerves. Nerves can be damaged in a number of different ways, with compression, with stretching, by being severed, that sort of thing. Often with this case, the nerve is being stretched, and you can imagine the neurons can only stretch so far before they go ping, 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 and they tear. So how might this occur? Well, it might occur if you fall off your horse and then you land on the side of your head and your head gets pushed away from your shoulder. So at that point you're worried about cervical vertebra injuries and the spinal cord, but you're also worried about the brachial plexus. It could also occur if you come off your motorbike and you slide across the tarmac and you think, yeah, I'm decelerating nice and slowly, and then you hit a lamppost, bam, and your shoulder gets pulled away from your head. The reason obstetricians are interested in this is because during birth, so when the baby's passing through the birth canal, if the shoulder gets caught, behind the pubis bone, so the head pops out, but the shoulder's stuck, I think what often happens here is the head appears and then disappears back in again. Turtling, something like that. Then, you know, if you pull on the head and the shoulder's not moving and a baby being somewhat tough, somewhat at risk of injury, then there's a risk of stretching the upper brachial plexus and causing this same injury. So it can occur during birth. Now, what does this look like? So what we see if the upper brachial plexus has been damaged is an effect on the nerves. Remember that, sorry, it's an effect on the muscles, obviously the nerves. Remember that all of the muscles in the body are working against other muscles. We have agonists and antagonists. When you make a fist, a seemingly simple thing like a fist, whilst the muscles on this side are contracting to cause flexion of the fingers and what have you, the muscles on the other side, some of them have got to relax to allow the fingers to flex, some of them have got to contract to prevent the wrist from flexing, and so on and so on and so on. If you're sat up, if you're stood up, you have muscles working with and against each other to give you that posture. I think you can imagine quite clearly what would happen if all of your muscles were switched off, if you were sat, right? So we have to think about that. In the upper limb, we have muscles working with and against each other. And if a nerve is damaged, some of those muscles are switched off. Well, they're weakened. They don't have the same level of tone and contraction as they had before. So what do we see? We see the limb hanging at the side of the body. So it's adducted. The humerus is usually a little bit medially rotated, and if this is supination and this is pronation, supination, pronation, we see the forearm pronated, and we may see the wrist flexed. And this is what gets described as the waiter's tip position. So I'm not laughing at that, I'm laughing at the noise that's occurring outside as I'm trying to describe this, as something's rattling along. So anyway, so we see what gets described in the textbooks as the waiter's tip position. So the humerus so the arm is adducted, the elbow is extended, the forearm is pronated, and the wrist may be flexed. Now, how do we get to this? From a damage to the nerves in the upper brachial plexus. All right, well, okay. So the brachial plexus, these are the roots of the brachial plexus up here, coming out of the spinal cord at various cervical levels. So the roots are C5, C6, C7, C8 and T1. And we can see some of these roots coming together, and this is very helpful because these are colour coordinated. So some of them come together to form trunks. We have an upper trunk, a middle trunk and a lower trunk. And if the shoulder is going to get pulled away from the head, it's the upper trunk that's most likely to get stretched. The other two trunks will probably be fine. And that means that the upper trunk, now have a look at this diagram. This diagram is your currently classical illustration of the brachial plexus from Wikimedia Commons. This is in the public domain. And what you can see there is you can see those roots. You can see how they come together to form the trunks. And we can see that it's C5 and C6. The C5 and C6 roots, those C5 and C6 spinal nerves are coming together to largely form that upper trunk. So then if the upper trunk is stretched, it's going to be the nerves coming from those C5 and C6 segments and levels that are going to be injured. So where do those C5 and C6 fibres normally go to? Well, we can see that the trunks, as they continue, there's a bit of crossing over, and we see divisions. So we see some of those fibres swapping across to other parts of the brachial plexus. And as we continue along, we see the cords. And the cords are named as they are arranged around the axillary artery. And you can see that most of those C5 and C6 fibres are going to go to the musculocutaneous nerve. Look at the axillary nerve there. So the axillary nerve is coming around here. They're going to contribute to the radial nerve. They're going to contribute to the median nerve. And if you look back and look really carefully, they're going to contribute to the suprascapular nerve. Now, some of those nerves, like the radial nerve and the median nerve, are also receiving a lot of neurons from other levels. So there's some backup, some overlap, some working together. But if you look at the musculocutaneous nerve, the axillary nerve and the suprascapular nerve, those receive pretty much all of their fibres, or indeed all of their fibres, from the C5 and C6 roots, which means that those are the three nerves we're most interested in: musculocutaneous, axillary and suprascapular nerves. But we need to remember that the radial nerve will also be affected to some extent, and maybe the median nerve. This brings us on to another idea. I talk about biology being more variable than the other sciences. We are biology. You can look at other people, you can see that they look slightly different, and if you look at the anatomy inside them, that's also slightly different as well. Now in this case, the severity of the injury can be different. So we're going to talk about these nerves and the effects of damage of these nerves, but bear in mind that the damage to the upper brachial plexus may be lesser or greater. Lesser damage will show you smaller signs and symptoms. Greater damage will show you greater signs and symptoms. So this is variable. And at the end, if I remember, we'll go back to what happens if you have an even greater injury and you damage the upper parts of the brachial plexus before they even become the brachial plexus. Anyway, okay, so back to those three nerves. Okay. Now, if we look at this young fella, so here's the neck, these are the scalene muscles here, here's the brachial plexus appearing from the neck, and it's going to run to the upper limb. We need to think about where those three main nerves go, the muscles that they innervate, and if those muscles are weakened, what happens? And that'll give us that presentation we were talking about. Okay, well, let's take the axillary nerve first. So the axillary nerve supplies the deltoid muscle. The deltoid muscle is doing what this guy here is doing. The deltoid muscle abducts the upper limb. There's a little bit more to it than that, but the deltoid it abducts the upper limb and also does flexion and extension of the humerus at the glenohumeral joint. So the axillary nerve has been damaged, it's weakened, which means you can't contract your deltoid muscle, which means that the limb is going to hang limply at the side. The limb is going to be adducted, and it won't be possible to abduct it. Now, if you know your shoulder muscle anatomy, if you know the musculoskeletal anatomy of the glenohumeral joint, you'll know that there's another muscle that starts off abduction of the upper limb. So you might think, but surely you could start abduction of the upper limb and then deltoid wouldn't be able to take it any further. Well, that's good thinking, because if we take deltoid off, spin around here, the suprascapular nerve is going to innervate these muscles of the rotator cuff. We've got supraspinatus and infraspinatus here. And these two muscles, well, supraspinatus is that muscle that starts off abduction. So the nerve to supraspinatus has been injured, so you cannot start abduction. The nerve to the deltoid muscle has been injured, so you can't continue abduction. So it will be impossible, or there'll be massive weakness, or it'll be really difficult, however you want to describe it. It will be the person will be unable to abduct the upper limb from the body. So the arm is adducted, which is the first thing we saw. Now, infraspinatus is one of the rotator cuff muscles that, here's the humerus here, that would cause lateral rotation of the humerus at the glenohumeral joint. So the nerve to infraspinatus has been damaged as well. There are other muscles here involved in that, but that means that you can see the humerus rotating because you can see this moving. So this is medial rotation, lateral rotation. So it's infraspinatus that would have a role in lateral rotation of the humerus. So if that muscle is weakened, that means that the other muscles that medially rotate the humerus, they'll have tone, whereas infraspinatus will not. So the limb will be a little bit medially rotated. Except you're not going to see that because the elbow is extended. So we have the first parts then. You can't, so the arm is adducted and medially rotated. Okay, what about the elbow then? The third nerve after axillary and suprascapular nerves that we saw affected was the musculocutaneous nerve. Now the musculocutaneous nerve runs to the anterior compartment of the brachium, or the anterior compartment of the arm. So if we take off biceps brachii, here we see the musculocutaneous nerve. So the musculocutaneous nerve is going to innervate the muscles of the anterior compartment, biceps and brachialis in particular. We see coracobrachialis here. Now biceps and brachialis are responsible for elbow flexion. So if the musculocutaneous nerve is hugely impaired, that means that elbow flexion will be impossible, and we won't have the tone of these muscles, we'll have the tone of triceps, even though we said the radial nerve that innervates triceps might be injured. There are some other nerves also supplying, other neurons from other levels also supplying the radial nerve. This means that the elbow will be extended because biceps will not be able to flex the elbow, nor brachialis. So the elbow will be extended, which we saw. There's a little bit more to this, because another job that biceps has is biceps is a powerful supinator. Biceps is a powerful supinator of the forearm, which means that if biceps is not working, if biceps has lost its tone, then the muscles that pronate the forearm will pull unimpeded and cause pronation. So we lose biceps and brachialis, we lose elbow flexion, and we lose a big part of supination. So that's why we then see the upper limb as extended and pronated. Does that make sense? Brachial plexus is difficult, but this shows us why the anatomy of the brachial plexus is so useful to understand clinically, because we can then understand what's going on, we can explain to the patient and that sort of thing. So the other thing to consider then is the wrist flexion bit. Basically, the wrist might be flexed because the muscles in the anterior compartment retain more tone than the muscles in the posterior compartment. So we get flexion of the wrist. That is to say, the radial nerve is more greatly affected than the medial nerve, and in particular, the neurons that innervate the muscles down here are not as affected as the neurons that affect the muscles here. So wrist flexion. Damage to deltoid and suprascapular nerves makes it very difficult to abduct the upper limb away from the body, which means we usually see the limb adducted at the side of the body, and also maybe medial rotation of the humerus because of the loss of the innervation of the infraspinatus muscle. The loss of the musculocutaneous nerve makes it very difficult to flex the elbow, so we tend to see the elbow extended, and it also makes it very difficult to supinate the forearm, so we tend to see the forearm pronated, and then the more neurons, so the retention of tone to a greater degree in the anterior forearm over the posterior forearm gives rise to elbow flexion. Elbow gives rise to wrist flexion. So that position. That's the crux of it then. So we think about the brachial plexus, we think about the roots, particularly the C5 and C6 roots, how they go on to form the upper trunk or the superior trunk of the brachial plexus, and then we think about the nerves that the superior trunk goes on to form. So we're also thinking about where the neurons from those C5 and C6 levels go. The greatest affected nerves are likely to be the axillary nerve, suprascapular nerve, and musculocutaneous nerve. So we think about the muscles that those nerves innervate, and then we can work out why those muscles lose strength, lose tone, and the muscles that work against them, their antagonistic muscles, are able to pull against them and pull the limb into that characteristic position. The other thing we need to think about then, what about sensory deficits? If you're damaging nerves, then you're going to lose some form of sensation, aren't you? So we need to think about that. Now, there are different ways of thinking about this. So if we think about the same nerves, well, the axillary nerve innervates the skin of the regimental badge area, that is the skin over the deltoid muscle. The musculocutaneous nerve, the musculo bit innervates the anterior compartment of the arm, but the cutaneous bit continues as the lateral cutaneous nerve of the forearm. So it would innervate the skin here. So you'd expect maybe to feel numbness here and here. But also we need to think about dermatomes. This is where the idea of dermatomes becomes useful. We said that the upper brachial plexus injury is an injury of the C5 and C6 spinal levels, spinal nerve roots. And now if you think about it, so have a look at this dermatome image. Now this dermatome image again is another one of your classical dermatome maps. This one is from Wikimedia Commons again. What you see is that the skin of the upper limb is innervated by different levels of the spinal cord in a certain pattern, which means that this matches kind of what we saw. So if the C5 and C6 levels are injured, looking at that dermatome map, you'd expect to lose some sensation from this region here, which is what we just described with axillary nerve and musculocutaneous nerve, but there are some other bits and bobs going on here. So there would be sensory deficits to the lateral brachium, that is the arm, and the lateral antebrachium, that is the forearm. All right? And you'd look and test for that. And I said earlier that there could be greater or lesser severities of this sort of injury. And I've spoken to surgeons about this before, surgeons that repair nerves with nerve grafts. And it's possible, and they have worked in these situations, where the roots of the brachial plexus have been torn from the spinal cord. Some of those injuries are irreparable, and some of, and slightly lesser ones are sometimes reparable with great skill, luck, care, and that sort of thing. But what would happen if the injury was closer to the spinal cord? Well, if we look at the brachial plexus image, you can see there are some other nerves that come off even earlier. Think about that long thoracic nerve. Now, the long thoracic nerve, for example, that goes down to supply serratus anterior. Serratus anterior is a muscle that stabilizes the scapula. So you'd lose much of the strength of that muscle, or maybe all of the strength of that muscle. You'd lose some of that scapular stability. You'd see maybe winging of the scapula and that sort of thing. So you'd start to see muscular effects closer to the trunk. But you could also pull out the connections to the sympathetic trunk. So you'd lose part of the sympathetic trunk on one side of the body. What would that lead to? Well, a number of things. But one of the things you might look for diagnostically is Horner's syndrome. I'm not going to tell you what that is, but it's up in the eye. Horner's syndrome. Okay, I'll put that on my to-do list. That's a video for another day. But what I'm trying to say is that not only are there variable severities of this sort of injury, but if the injury gets close to the spinal cord, more things will be affected, and to a greater degree, which is maybe what you might expect anyway. Okay, just to leave you with that morose thought. Yeah, okay. And as somebody who rides a mountain bike and occasionally crashes a mountain bike and goes rock climbing and things like that, I do worry about my head, neck, brachial plexus and that sort of thing. Anyway, that's it. Hopefully that was vaguely clear, and you have not only a better understanding of Erb's palsy and an upper brachial plexus injury, but you can go through those same steps to describe why the position of the upper limb that we see is associated with an injury to the upper brachial plexus. We'll also look at injuries to the lower brachial plexus one day in the future, I think. What's that called? Klumpkeys? 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 Yeah, anyway. Right, I'm going to stop talking. It's almost gone quiet now. That's typical, isn't it? Except for that banging of that door there. Now that I finish